Thank you, Jill, and thank you everyone for coming. So as Jill said, today I'm going to briefly talk about how the linked administrative data or routine data from our BIB for All cohort is being used to support a local research priority around perinatal mental health. I started this work during my PhD, and I'm now lucky enough to continue to do this research as part of my current research fellow role. So firstly, what is the BIB for All cohort? So you may have heard of Born in Bradford, which is a large cohort that's been tracking the lives of families in Bradford to explore the influences on health and wellbeing. They've collected bespoke survey data and biological samples, but crucially, they've gained consent to link to data that's routinely collected by public services like health and education. And through accessing these routine data, Born in Bradford were able to demonstrate the value of linking and using these data to follow families over time and for decision making. So in 2019, Born in Bradford launched this new study called Born in Bradford for All, or BIB for All. And this study gains consent from pregnant women to link and use data that's routinely collected about them and their baby for research. So some of the organisations that collect data on families that can be linked together for our participants are on the screen. And recruitment for BIB for All is embedded within routine antenatal care. And what this means is that every pregnant person who's booked to receive maternity care at Bradford Teaching Hospital is invited to join the cohort by their midwife as part of their standard care. And this is why it's called Born in Bradford for All, because the study is open to all pregnant people and recruitment will continue indefinitely. And this creates what we are calling a cohort for every generation, where the data from consented mothers and their babies can then be used to shape local services. The study is therefore founded on this idea of this learning health system, where we use data from the system to then inform improvements to the system. As part of the consent process, we also have permission to contact these women about other research opportunities, and this essentially creates this pool of participants that we can then contact about other research, so trials or qualitative research, which kind of makes it a bit unique. So the consent model was proved to be successful, and other local areas then approached us and said that they would like to set up a BIB for All in their local area. And this prompted the decision to adapt the study from a Bradford-based single-site study to this broader multi-site study that supports a network of these cohort studies, which is known as the Baby Network or Born and Bred in Network. And here are all the cohorts that are currently open to recruitment that are being supported by the BIB for All team to set up a study like this. The primary aim of BIB for All and each of the other baby cohorts is to use routine or administrative data to answer locally relevant questions that can then be used to support the health and well-being of each of those local populations. And each baby site is encouraged to collaborate with a range of local partners at this level to achieve this aim. So in Bradford, we collaborate with local partners in Bradford to ensure that our data is being used to support local need. So two of the directors of the Baby Network developed this model to illustrate how routine data can be used as a local health intelligence tool to support local policy and practice. And I'm going to talk through a little bit about my experiences of using data from BIB for All to support a local research priority. And as many of you will probably know, working with routine data is really tricky. So despite setting out with the intention to inform practice, a lot of the work that I've been doing is understanding how we can get the data to a place that it can be used as local health intelligence. So the first step of this process was to identify what priorities are locally in Bradford that the BIB for All data could be used to address. And to do this, I engaged a range of local stakeholders in Bradford, and this included members of the public, commissioners, earlier service providers, midwives, health visitors, and other relevant stakeholders in a series of workshops. And the identified research priority focused on exploring the relationship between mild to moderate mental ill health during the perinatal period and child development. So the next stage is then to use the data to address this topic. And in theory, data on a mother's mental health can be recorded by maternity services, health visiting services, and also primary care, as well as other specialist services. And child development data should be collected routinely by the health visitors as part of the 2 to 2.5 year health visiting review. So they collect ages and stages questionnaire outcomes, and this is a screening tool for child development. But what we wanted to understand was whether the BIB for All data could actually be used to address this question. So in theory it can, but is the data of a usable quality in order for us to do that? So what did we find? When we accessed the data, I found that key information needed to address this research priority was not available or captured in a way that was useful for research. So I found that ages and stages questionnaire data was available for less than 50% of the children in the cohort. And to make use of the mental health data, I used a composite measure of mild to moderate mental ill health developed by another team at Born in Bradford. However, when we used this measure, it was quite sensitive, and there was also quite a lack of understanding of how services actually record perinatal mental health. So, for example, there were lots of codes and terms that related to general mood observations. But this doesn't actually mean too much about a patient's health, and it doesn't tell us much when we're pulling out the data in order to understand the level of need. So it was really challenging for us to use that information to understand which women were actually experiencing perinatal mental health problems during that time. So what I did was I shared these results with some local stakeholder groups, so the Best 1001 Days Steering Group and the Perinatal Mental Health Steering Groups that we have in Bradford that have stakeholders across the whole district. And I also regularly attend these meetings, so we've kind of developed this collaborative relationship over the time that I've been attending that. So the decision, so as a result of sharing my findings with members of these groups, the Perinatal Mental Health Steering Group were really keen to work with us to understand how their data could be improved. They want to be able to use their data to identify gaps in service provision and also ensure that they're supporting the women with the most need. Through talking to these groups as well, healthcare professionals providing care to women during the perinatal period have expressed their frustrations with the system because they spend so much time collecting data that they know is not that useful. And this has kind of led to their motivation to drive forward these changes that will then improve the usefulness of their data. So based on the needs of the steering group, I've kind of done a bit of a deep dive into the data that's collected by services. And this has included mental health data as well as demographic data recorded in maternity and health visiting data sets for our BIB for all participants. And this was with the aim of understanding what the gaps are in data collection for helping us to understand inequalities in access to services. This work is still ongoing, but the plan is for this analysis to inform a data workshop, which we've got planned for December, which will bring together local services that provide perinatal and infant mental health support. And at the workshop, services will then discuss potential improvements that can then be made to routine data capture and what the next steps are to implement these changes based on our findings. We plan to share this learning quite widely and throughout our baby network to hopefully influence national policies on the way that data is captured in order to support service delivery, but also research into these areas. So I'll just give you a flavour of some of the findings we've got so far. These relate to Bradford systems, but other local areas may face similar issues, and based on anecdotally, we think that they might. For context, maternity data in Bradford is currently recorded on the electronic patient record system called Cerner, and health visiting data are recorded on System 1 using CTV3 codes, and that might hopefully be meaningful to some people on the call. As researchers, we were able to access data from a woman's booking record with maternity services and any mental health data that was recorded using a maternity mental health status form, and that's just the way that the data was recorded in the Cerner system. From this, we had information on family history of mental health, which clinicians have described as prediction questions. We had outcomes of Hollie questions, PHQ-9, GAD-2 and GAD-7, which are all questionnaires which are used to identify poor perinatal mental health for anxiety and depression. And we also had data on mental health referrals and whether this was accepted or declined. And the options that we had included whether they were referred to a perinatal mental health team, a consultant, a GP referral, a health visitor referral, a referral to talking therapies or other. From this, we found that only a small number of BIB for all women, approximately 4%, had a positive response to the Hollie, and approximately 3% were identified as having mild to severe anxiety or depression symptoms. And this is significantly lower than we would expect, as NHS England estimates that approximately 1 in 5 new and expectant mothers are affected with perinatal mental illness. Using these data, we also found that none of the women who had been identified as having poor perinatal mental health had a record of being referred to services. And after further exploration, we think that this is due to the system and the way these data are captured. So, for example, if a mental health status form was used, there was no section that would then allow the clinician to enter referral information. So what would happen is the midwife would attach a Word document which would have all this information in. But if you wanted to extract that information as a researcher or for analysis, it wasn't that accessible without going into each individual patient's record. So what we found was that actually the data that we can extract from those records is not actually that helpful for understanding referrals to support services. In terms of demographic information, we accessed ethnicity data, spoken language ability, age of booking, parity, and we were able to derive the index of multiple deprivation from postcode. These were well completed, but from speaking to midwives, we found that ethnicity data is not inputted by them and it's informed by a GP referral. So midwives have reported that this data can be unreliable and it should be used with caution. In the health visiting data, we found that the codes that we could access related to observations of mood, and these were reported most frequently. However, these observation of mood codes are not actually that helpful, again, for telling us much about the patient's mental state, only that their mood was observed. We found that 46% of women had a record of being asked a screening or detection questions for perinatal mental health, and less than 5% of the bib for all women were identified as having poor perinatal mental health in their health visiting record. Again, this is less than expected, and we think that a lot of the detail about a woman's mental health is recorded in the free text fields. Demographic data was not well completed in this, but luckily with bib for all, we're able to link to maternity services, so we were able to look at some of that data for those women. The next steps are to understand these findings within the context of clinical practice, and this will be explored at our data workshop. So based on our findings up to this point, we would recommend that the maternity system is updated to allow referrals to mental health support to be documented in the same place as the detection and identification questions, and this would allow us to more easily extract this information when making key decisions. This would likely be an expensive task, but as services are on board and are lobbying for this change, this might make change more likely to happen. We recommend that researchers speak to health visitors to understand how mood observation codes are used, and we recommend that researchers explore with both maternity and health visiting services if there are any additional places that mental health data are recorded that can be used for research and service provision. So to complete this cycle, we'll hopefully be able to make some changes to the way that data are captured, and we're hoping to communicate our findings with local commissioners. We've already got that meeting booked in. And the data itself can then be used to evaluate whether these changes have made a difference. So for example, is routine data more helpful for understanding perinatal mental health need in Bradford? So in summary, this model, which has been built on the foundations of local collaborations, is helping pave the way for us to be able to use these data to support policy and practice around child and maternal health, because it's provided us with this mechanism for speaking to local services and data providers in order to improve these data. In Bradford, like I said, we're working with local services to identify the gaps in the data and then how we can then go about making those changes so that the data better meets service need. And as perinatal mental health was identified as a local priority, it's kind of created this impetus for change. I'd just like to acknowledge the families and the healthcare professionals who make this study possible. And like I said, this was part of my PhD research and is now part of my research fellow role. Thank you for listening, and I invite any questions you may have. Thank you very much.